Welcome, everyone, and thank you for joining us today. You know, as leaders and providers, how many times a day recently do we hear or make decisions in the context of unprecedented times, uncharted waters? As this public health emergency and health crisis began to unfold, we at Aegis, along with, I'm sure, most, if not all of you, identified resources, additional resources, to ensure that our responses, our services, and our engagement with patients, customers, and communities was grounded in fact, and our actions were appropriate to the changing landscape of knowledge and experience as all this has unfolded. I'm confident we all share the common goals working together to ensure the safety of our patients and employees. Our presenter today is a key critical resource we added to our team at the onset of this crisis. He has been an incredible partner. Dr. Jim Avery is a highly respected, deeply experienced expert in long-term care, home health, and hospice. He brings his years as a pulmonologist to this COVID-19 challenge. Presently, he is the National Medical Director of Diversicare Healthcare Services, as well as visiting assistant professor of medicine at the University of Virginia Medical School Division of General Medicine, Geriatrics, and Palliative Care. I've had the privilege of working with Dr. Avery over many years and thank him so much for joining us today. And with that, I will turn it over to you, Dr. Avery.
Great. Thank you, Martha, and thank you, Mark. It's a privilege being here. This is a key topic. If you turn on the newspaper, turn on the TV, or read the newspaper, headlines are blaring. And what I want to do is cut through all of the headlines, cut through everything, and give you the confidence you need to understand coronavirus and to manage it in whatever setting, whatever healthcare setting you're in. Okay, let's go to the next slide. We'll start with some basic information. Yeah, the coronavirus is, everybody on this call has probably been infected by a coronavirus. Usually it's manifested as a pink eye or a common cold, but COVID-19 is a little bit different. Like all of these, it tends to come from animals, camels, if you've been hanging around them, cattle, cats, mice, and bats are very common, and it's called corona because it looks like a crown when you see it under the microscope. Next slide. So a couple of years ago, my family and I went to China and we saw markets like the one I'm showing you in the picture here in Wuhan, China. And what you see here is their open air market, live animal market. And the speculation is that this went from an animal that had a disease to a human being and then throughout the world. Now, we've had outbreaks of coronavirus in the past. SARS back in 2002 and MERS in 2012. So we have some knowledge about coronaviruses and about when they become outbreaks. Next slide. Now, COVID-19 is a little bit different. It was classified as a pandemic. When I was talking to my neighbors and they had the pandemic designation, immediately I was getting phone calls. Oh my goodness, this thing is deadly, it's severe. Remember this, pandemic doesn't refer to the severity or the deadliness of a disease. All it means is that it's more widespread, that it actually has spread to multiple geographic locations, and in this case, pretty much around the world. Okay, next slide. If we look at the cases in the US, this is a few days old at this point. Johns Hopkins University, by the way, has a great website. You can see where the hot spots are. We have them in the Northeast, we have them in Florida, Georgia, Texas, Mississippi is and Georgia getting hit pretty hard. California and Washington State is improving. Let's go to the next slide. Now let's talk about disease. Let's talk about this disease and let me give you the scientific information, the best and most up-to-date clinical information. COVID-19 is a respiratory virus. That means it spreads in air droplets when someone coughs or sneezes. People within 6 feet, are most likely to get sick, and the viral particle would have to land on a person's mucous membrane. Eyes, nose, and mouth, but mainly nose and mouth. Those are the portals. That's the door That's the opening, okay? You're going to hear more about this. I want to emphasize that your nose and your mouth are the opening for a respiratory virus. So the virus can land directly on you. You're talking to somebody very close, they cough, they sneeze, uh, but it can also happen when they cough and sneeze on a surface. And then you touch that surface. Will you get infection then? No. You have to then touch your eyes, your nose, or your mouth. Okay, next slide. Now, this is just to remind me, if I haven't done it well enough, that the key is eyes, nose, and mouth. And really, when you come down to it, nose and mouth are mainly the issue. Now, on the next slide, we'll see why that's important. COVID-19 tends to spread by large infectious droplets and small infectious droplets. Right now, at this moment when I'm talking to you, there's no evidence that it spreads through droplet nuclei. Droplet nuclei are when it dries out and it can still be contagious. That's true, for example, in tuberculosis. But that's not true of COVID-19. So if you're looking at this slide, it's the large infectious droplets, notice 1 to 3 feet, small infectious droplets 3 to 5 feet. By the way, those distances are even less in areas that have high humidity. And that's why in the summertime, and as we have warmer weather, we tend to see less infections because droplets fall to the ground even shorter distances. Okay, let's look at the next slide. So lab research, this is in the New England Journal of Medicine, says that viruses can remain airborne for 2 to 3 hours. You have seen these headlines, I know, and they remain viable on surfaces for the following periods. Oh my good, plastic and steel, 72 hours, cardboard, 24 hours, copper, 4 hours. Now, when you see those numbers, you think, what do I do with my Federal Express package? What do I do with anything? It's everywhere, right? Next slide. Those studies were lab studies, and that's where someone gets a Petri dish, and this is another lab study, and we find that the virus half-life, meaning when it's on stainless steel, when it's on plastic, even shorter for cardboard, much shorter, half of it dies within 5 hours. Plastic, half of it dies within 6 hours, and on cardboard, it's something like 2 hours. So within if you have your UPS guy sneeze on the package the day he gives it to your door, half of it dies in 2 hours, another half 2 hours later, and on half-life goes. So on the next slide. So Johns Hopkins did a study, and what they found was at 72 hours, yes, you could grow the virus out on a Petri dish, but there was only 0.1% of the starting virus material remaining. That's 1 out of 1,000 virus particles. In other words, the infection is theoretically possible, but extremely, extremely unlikely. It's almost like winning the lottery if you can get it that far out. So always be careful when you hear the news reports and the TV reports. Is this a lab data, or are they really doing studies that are clinically relevant for you and for me as clinicians, as people by the bedside? Okay, next slide. I'm going to talk more about that in a second, but I know this is the question everybody's asking. What about my pets? And this just came out yesterday. And what they found in the journal Science and researchers in China, that if you have a ferret or a cat, they are highly susceptible to COVID-19. Dogs, on the other hand, less susceptible. And your livestock, including your pigs, maybe you have a pet chicken or maybe you have a pet duck, they are not susceptible to the virus. So if you have cats or ferrets, you may want to switch to ducks if you want to avoid COVID-19. Let's go to the next slide. And I want to emphasize what I did before as we get back to more serious topics, that always think about, is it a lab research or is it clinical research? Remember, the lab research is not saying what's really happening. That's done by Petri dishes and swabs, while the clinical researchers will tell us more. from this moment on, I will mainly be focusing on the clinical research, the stuff that we know is actually happening, not what people in the lab say, because often, as you just saw, that's not as relevant. Okay, and in fact, the cat studies and the dog studies and the duck study that was lab research, they haven't really seen a whole lot of clinical disease in animals, but I wanted to throw that in. Okay, let's talk about spreading by touch. Here's a possible scenario. A COVID-19 patient is in your nursing home or your ALF and they sneeze on a plastic chair. You happen to walk into that room and you happen to sit down and you touch the exact same spot on the chair. Will you get infected? Think about that just for a moment. Only if you touch your face or mouth or eye before hand washing or before using hand sanitizer. Here's a clinical study. Spouses of an infected person, the husband and wife who live together, share the same bed, share the same house, only have become infected in about a little more than half of the cases. So now you're starting to see why I emphasize the face, the mouth, the nose, and the eye. Okay, next slide. One of the key definitions that you need to know and focus on is this definition of prolonged close contact. That's the CDC term. That's the medical term for exposed. Someone says, have you been exposed to somebody with COVID-19? These are the criteria. You live in the same household as a sick person. You're caring for a person and you're unprotected. You're within 6 feet of an infected person for more than a few minutes. And most people define a few minutes as 10 to 15 minutes. Or you've come in direct contact with secretions from an infected person. They coughed right in your face, they've sneezed on you, you've kissed them, you've shared a toothbrush or fork or something with them. These 4 criteria are what define an exposed person, a person who's had prolonged close contact. All right, definitions are great, but let's make this real on the next couple slides. So you're sitting in a crowded lecture hall, which don't exist, don't exist anymore. But we're playing a game to educate. Is that prolonged close contact? So say you're walking out of the lecture hall, you get a ding on your cell phone, and they say, "Hey, 3 people in this lecture hall just told us they are positive." Did you have prolonged close contact? Yes or no? Think about it for a moment. Okay, next slide. Let's get the answer. Maybe the answer is sort of a trick question. If you were within 6 feet of an infected person, or those who were sick coughed on you or sneezed on you, you would be at increased risk. Now, let's use common sense here. You have your nose and your mouth and your eyes. The virus has to get there. So if the person is 6 feet behind you, it might be less likely. Or 6 feet in front of you, you're more likely to give it to him, especially the way this lecture hall is situated. Okay, let's go to another possibility. So you're delivering a food tray. You take the food tray, you bring it into a patient's room. Now they're COVID-19 positive, but you don't know it. So they're COVID-19 positive. You walk in with a food tray. You talk to them, say hi. You put the food tray down on the side. You take the cover off the coffee. You take the cover off the food. You exchange some pleasantries and you leave. Is that prolonged close contact? Yes or no? Next slide. No. Briefly walking by, and this is, by the way, right from the CDC. Briefly walking by or being briefly in the same room as a sick person with COVID-19 does not put you at higher risk. Now, if that person were to cough right on you while you're there or sneeze, obviously the answer would be different. Okay, let's try another example. Hopefully you're starting to understand now. It's becoming real what we mean by exposed, what we mean by prolonged close contact. So this therapist is helping a resident ambulate. Is this prolonged close contact? Yes or no? Now look carefully at this picture because I spent a lot of time getting this exact picture. Okay, next slide. The answer is maybe, but not for this therapist. Notice she is staying behind the patient. So try to limit face-to-face time. That limits your exposure. Now, clearly she's within 6 feet. She's holding on to the belt so he doesn't fall. And she will need to make sure she follows this visit with good hand hygiene because she could have the virus on the belt, right? And she should not touch her eyes, nose, or mouth. So even though she's within 6 feet and would probably answer yes to prolonged close contact, her chance of getting it in this setting are very, very, very low. Okay, let's move on to a different topic and let's look at incubation period. You need to know this. Coronavirus has a median incubation period, and this is the most recent data of 3.96 days. Let's make it 4. Incubation period, that's the time from exposure, you get coughed on, you get sneezed on, till your first symptom, okay? So 4 days is average. Now I've been in contact with probably dozens of people who have COVID-19 positive, and I ask everyone, when were you exposed? When do you think you got exposed? And it's really holding at 3, 4, 5, 6 days. Theoretically, 2 to 14 days is what we're saying, because that's from the lab results. But practically, we're seeing really 3, 4, 5, maybe 6 days. In comparison, influenza has a much shorter period of just 2 days, and it's almost guaranteed. You kiss the person with the flu on Sunday, you get sick on Tuesday. With coronavirus, a little wider period. And during that incubation period, people don't feel ill. Remember, it's the time from exposure to the first symptom. Okay, next slide. Now, why am I really emphasizing this? Well, first of all, people can be contagious during the incubation period, but the most recent information from the CDC is saying we're seeing nasopharyngeal swabs positive about 48 hours, about 2 days before the first symptom. That's the key thing. Where was the person when they first get their symptom? Where were they in the last 48 hours? Now, because the lab results show us incubation period can be 2 to 14 days, that's why the CDC has a 14-day self-quarantine period. But honestly, if a person is self-quarantined and they're 7 days out, the odds of them then getting sick is extremely unlikely, although we still recommend that 14-day period to be extra safe. And this explains our challenge in keeping the virus out of your facility, because people walking around feel perfectly fine. And that also gives you the limitations for taking a person's temperature and the limitations of asking questions and screenings. So let's leave that for a second and let's talk about the symptoms. What kind of symptoms are we seeing? Now, they can range from nothing, 25%, to mild to moderate to severe. Young people particularly don't have any symptoms at all, but a recent study showed about 15 to 20% of the elderly who are testing positive for COVID-19 say, hey, I didn't feel anything at all. I feel just fine. So let's go to the next slide. Now, the most common symptoms, and this is from 55,000 confirmed cases, are fever, cough, and shortness of breath. Those are the big boys. Those are the ones you want to think about. Sometimes the cough is dry more often. Sometimes the cough is productive a little less often. Fatigue is also seen, but fatigue is so ubiquitous in people, it's a hard one to use. Let's go to the next slide. Now, when you look at these symptoms, you notice that they're primarily lower respiratory tract, which means most of the symptoms are being felt in the chest and lungs. And this is different from colds and seasonal allergies, which really is in the upper respiratory tract. Think about runny noses, sinus congestion, and a cough on the next slide. So right now, if you were to give me the survey, you would say, Dr. Avery, do you have a cough? And I would say yes. And then you would say, is it recent? And I would say yes. And they would say, you shouldn't be in our center. Well, not true, because my cough is clearly a postnasal drip cough from allergies. The allergies are crazy. The pollen is crazy here in Virginia, and I get this every year at the same time, and I have some nasal congestion with it. COVID-19 tends to give symptoms in the lower respiratory tract. Now, people can get a sore throat from it. It does replicate in the throat, which is one of the reasons it's so contagious, but the symptoms tend to be more lower. So that can help you a little bit. Next slide. And what we have found is that in the moderate and severe cases, it attacks the lungs, and it attacks those most vulnerable. People with lung disease, smokers, heart disease, people with diabetes. Men seem to be affected more than females, and people who are elderly. By the way, if you're a smoker, this is a great time to quit. Now, when we look at people who get their lungs attacked by COVID-19, what we're finding is a higher percent get double pneumonia, bilateral pneumonia, pneumonia in both lungs. In fact, when they did CAT scans on people, they found abnormalities in 86% of the cases. On the next slide, that is extremely unusual. I'm a pulmonologist. I've seen, I don't know, thousands of pneumonias, maybe more. Bilateral pneumonias, when you have it in both lungs, that is not very common and it's always significant. So here you can see an x-ray of a normal lung on the left, and it's nice and black, and the black is air. Air is good, black is good, air is good. If you look at the x-ray on the right side of this picture, we see bilateral pneumonia. We see this means infection in both lungs, and that's a severe problem. And let's talk about severity on the next slide. Now, after looking at that horrible looking lung, which frightens the heck out of me when I see it, um, the facts are this. About 90%, 9 out of 10 people who get infected really have no or mild or moderate symptoms. They may never see a doctor. They're going to completely recover. 81% was the number we were quoting a week ago, and that's now up to about 90%, because as we test more and more people, we're finding more and more people have it and yet had very mild disease and really didn't think they had it, or just knew they were exposed, or just wanted to make sure. Next slide. Now, about 1 in 14, though, will have moderate to severe disease, the pneumonia like we just saw, and about 1 in 30 will have critical. I have this picture here of 30 people. So if 30 people were to get COVID-19, one of them, this thing can be life-threatening. But it's not everybody. In fact, let's look at mortality for a second. How many people who get it will die? Now, this is important on the next slide. Tom Hanks was a good example of this. I had a neighbor when Tom Hanks first got this who said, is Tom Hanks going to die, Jim? Is that what happens now? The mortality rate, the number of people who die, is only 1 in 200. So I have 2 people in red here. Really, it should just be 1. So knock out the 1 person on the left side. It's only 1 out of 200 are going to die from it. Now, for normal influenza, for the average moderately season, it's about 1 in 1,000. So this is 5 times the amount. But now suddenly it's not, as you might think when you read the headlines, COVID-19 is not a death sentence. COVID-19 makes the odds of dying from it are actually very, very, very slim. Let's go to the next slide. Let me give you an example here. Now, I like this slide, but 1 out of 4 people in this country is mentally imbalanced. If your 3 closest friends seem all right, then you're the one. That is not true. And it's not true for COVID-19, meaning if you have 200 friends, is one of them going to die if they get it? No. Next slide. Because like mental disease, COVID COVID-19 doesn't impact everybody equally. You know this. You've read the headlines. Notice this. People who are young, the death rate by age is so very low. Now, there will be cases, and every case of a young person dying is going to be on the front page of your newspaper, making you think it's more often than it is. However, look at people over 60, over 70, over 80. Over 80, it's 1 in 7. Over 70, it's going to be 1 in 12. That's the issue with COVID-19. That's the problem right there. Okay, next slide. Let's go to diagnosis for a moment. Now, the one that we're doing that you're getting done is called the PCR, and on all the tests pretty much, and that's polymerase chain reaction test. And what it's looking for is genetic material from the virus. So you put a nasal swab into the nose, and it becomes positive shortly after they're exposed to the virus. And the highest will be a couple days before, remember 48 hours before symptoms, but it's highest the first few days of symptoms, right when the cough starts, right when the person starts feeling short of breath. And after 5 to 7 days, it decreases pretty quickly. And in fact, most people feel pretty good about a week later. There is an antibody test, and they are contacting nursing homes and ALFs and saying, why don't you buy our test kit? Do not buy these test kits. These measure the antibodies in the blood, and they become positive far too late to help you with decision making. They become positive 5 to 14 days after symptoms. The good news is the PCR test that we're getting, it used to take a couple of days to get back, then 1 day, then 30 minutes. Now they have tests that can give you the results in 5 minutes. One more thing about the PCR test, because that's the one you're doing. Well, let's go to the next slide. The PCR test has no false positives. False positive is when a test comes back positive, but the patient doesn't have it. For example, all of us have known people where the doctor says they have cancer, but then they go in, do a biopsy, and it's like, no, you don't. Uh, that's a false positive. False negative, though, means the test comes back negative, but the patient has it. Why is it 30%? Why is so many tests coming back negative when the patient is positive? Number one is poor sampling. You don't get enough secretions on the swab. You're not swabbing deep enough into the nose. Do not relegate the test taking to somebody who is timid. This swab needs to cause some discomfort. It needs to go deep enough and move it around. You need enough secretions. You don't want to have false assurance because you're getting a negative test. The second reason is the sample degenerates if it's not tested in a timely manner. And they have found that some samples taken on a Friday, if that lab is not open on Saturday and Sunday, are coming back negative more than they should. That's why the new tests, the instant tests, are much better. The other thing is you can get a false negative if you test too early. Remember, about 48 hours before symptoms is where the virus starts to show. And then after 5 to 7 days, the viral loads drop dramatically, and that's going to be negative. So when you do your PCR test, do it properly so you can decrease these false negatives. Okay, let's summarize what we've discussed so far. This is a widespread contagious disease. It's a pandemic. People who are infected and contagious might be feeling perfectly fine or only a little bit ill. Why? We said the incubation period, remember, average 4 days, but up to 14. And there's a lot of people with very mild disease who are walking around and might feel a little gimpy or nothing at all. And the big problem is our elderly, frail, and end-of-life patients are very, very vulnerable. I should add those with lung disease, those with heart disease, those with diabetes, and dialysis patients. That should be added to that slide. Okay, let's go to the next slide. So we know our problem now. Here's our challenge. How do we limit infections in our staff, in our residents, in our patients? How do we give our patients and families peace of mind and confidence? And the big question, how can we optimize care and mitigate exposure. Okay, next. So one thing, we all are doing this. I know I put checks by it. I know you're doing it, but I just want to remind you, train everybody in respiratory hygiene and cough etiquette. Infection control on equipment and environment needs to be upgraded. We're restricting all locations to essential visitors. Follow CDC guidelines. Wake up the complacent. But as you are learning more and more scientific data today, you should be able to wake up the complacent, but you should comfort the worried and panicked, because the scientific data is a lot better than the headlines that you're hearing on the news and on TV. Okay, next slide. So we know to restrict all essential visitors, but let me remind you, look at in red down there. It's your own staff that poses the greatest risk to your other staff and your patients. Next, that's why I want you to double down on directing workers to stay out of the public. Give them advice. Tell them how to go grocery shopping. Tell them, what do you do with packages? Curbside pickup. Stay away from people. Social distancing. You want to help your folks to stay out of the public. Why bring that virus in by not being careful once they're outside? Next. One of the problems, of course, is workers who go to multiple facilities. If somebody's in a COVID-19 positive facility, they should not visit another facility that's negative in the same day. Best practice, if possible, visit one facility per day. Next. We all know about screening staff, and we know we have to ask about respiratory infections, fever, cough, a new respiratory infection, that's the key. Fever, cough, shortness of breath, sore throat, and also one you can put in there. Lately, interviewing people, we are seeing some people with more muscle aches, and that tends to be, I've noticed, people who have arthritis before. Like they have a bad knee and suddenly that knee is flaring up, that can be an early sign. Now, in the last 14 days, if they've had contact with somebody, and by contact, I mean prolonged close contact. If you've been exposed to somebody, I often get questions. I've been exposed to John, who was exposed to Karen, who was exposed to, Ellen. Am I at risk? Well, no, it doesn't go like that. Being exposed is contact with the person with the disease, and of course, international travel anywhere, or travel from New York, New Jersey, or Connecticut within the 14 days needs to be quarantined, or at least be sure they're wearing a mask and they have no symptoms. Okay, next. Now, when there is a severe staffing shortage, the CDC is allowing healthcare workers to care for people, even if you've had prolonged close contact, as long as they don't have any symptoms. But they must self-monitor, they must wear a face mask, and stop working if they develop symptoms, even mild ones that are consistent with COVID-19. Now, everybody should know by now, everybody in a facility, if you have them, should be wearing a face mask. Face mask is the key. We've talked about this. If you haven't gotten it yet from this lecture, your nose and your mouth are the key things. All right, let's play a game on the next slide. So you're on a desert island with another person, and they are COVID-19 positive. You can see the message arrived by Shell, and one of the people is COVID-19 positive, but you're not. It's the other person who's COVID-19 positive. So next slide. So notice you have a phone there on the palm tree. So you pick up the phone and you call and you say, hey, can somebody send me some PPE? I'm on this island with this person and they have COVID-19. And they ask, I'm sorry, we can only give you one type of PPE, only one type. Which one do you want? Do you want a gown? Do you want eye protection? Do you want a face mask? Do you want gloves? Or do you want covers for your shoes? Which PPE would you pick if you're only allowed one? Okay, next slide. The first choice should be obvious. Face mask. Number one, nose and mouth. That's the key. Number two, eye protection. Next is gloves, and next is gowns. A quick word about face mask. There have been some studies that people who don't wear face masks properly actually can increase their exposure. And there are people who just fiddle with the face mask all the time, meaning they're touching their face all the time. They're readjusting it. They're touching their cheeks. They're touching their eyes. So don't touch your nose, your mouth, your eyes, or your face mask. And when you remove it, remove it from the strings. Okay, next question. Now, you're on this island with this person. The face mask came by, I don't know, by who knows how, on a turtle's back. Uh, but they only sent you one. Who should wear the one face mask? Remember, the COVID-19 positive person, they're already sick. We want to protect you. So, one mask, you and the COVID-19 person, who gets the mask? How do we protect you the most? Do you put it on yourself or do you put it on the infected person? Next slide. And what we find is the studies are unequivocal. They're clear as can be. You put the mask on the COVID-19 positive person because that will protect you the most. The CDC and medical experts call this source control. There's real controversy now about should everybody in the streets wear a mask. And this is the reason. We know masks are most helpful for those who are infected. That's how you prevent it from spreading to others. They're also helpful for the healthy person, but not as much. Okay, next slide. Now you're thinking, what about homemade face masks? I mean, we can give a whole lecture on them. Scott Siegel is an anesthesiologist who has studied face masks. He says there's a simple way to do it. Hold it up to a bright light. If the light passes readily through the fibers, it's not a good one. If it's a denser weave and light doesn't pass through as much, that's the ones you want to use. New York Times and their review of homemade face masks said, think pillowcases, think flannel pajamas. You don't need them anymore. It's getting warm now. The CDC says in settings where face masks are not available, use them as a last resort. And they like to say use them in combination with a face shield that extends to the chin and below if you have it. Okay, next. Now I'm changing topics a little bit here because I'm trying to address some of the things that I hear a lot. What is common is still common. What do I mean by that? Well, let me give you an example. So a man, he's sitting in his home office and he hears hoofbeats outside his window. Now he can't see outside his window, but he hears hoofbeats, the galloping sound. And what could it be, he wonders. Next slide. Is it more likely to be a horse or more likely to be a zebra? Well, I'm in Virginia. I can tell you it's very unlikely it's going to be a zebra. It's going to be a horse, right? Maybe a deer, but more likely a horse. Next slide. I just want to emphasize that what is common is common. We've had nursing homes call me, patient has a fever, and it's obvious they have a urinary tract infection, yet they're worried about COVID-19. What is common is going to remain common. Urinary tract infections are going to remain common. Infections of the wounds are going to remain common. Do not think every fever is COVID-19. In fact, do not think every cough or nasal congestion is COVID-19. Allergic rhinitis is rampant right now. We still have cases of influenza floating around, and the common cold likes to come in during change of season also. And these are the latest numbers. COVID-19 is still less common. Now, you have to think, well, let me go to the next slide. And this is from the NIH, and they're trying to help people to make these decisions. And what they're saying is, do you have shortness of breath? That puts you more on the COVID-19 side and the influenza side. Do you have itchy eyes? That puts you a lot more on the allergy side and the common cold side with the runny nose and that kind of thing. So just keep this in mind that what's common is still common. But, next slide, we have to consider geographic risk. In other words, if you go to this website, www.coronainusa.com, put in your hometown, you can see how many cases there are near you. I live in Charlottesville, Virginia. I just went on this site 2 days ago, and you can see there are 48 active cases near me, 1 death. And then within 60 miles, there are 300 cases and 52 deaths. You can do the same thing for your hometown and get an idea how bad it is or how not bad it is. Next slide. In addition, if you go to this site, www.healthdata.org, you can predict the risk and timing for your state. This is Virginia again. You can see we're due to peak at a certain time. And this changes every single day. This is the data the federal government is using. This data is really holding very well. So for example, I was talking to a nursing home in Mississippi just yesterday, and they were saying, do we have to put beds aside for patients coming out of the hospital? Can we get testing done? What should we do? Should we take new patients? I went on this site, plugged in Mississippi, and what I found was their hospitals are never going to run out of ICU beds or beds like we saw in New York City. They have plenty of ICU beds and beds in Mississippi based on these projections. Therefore, they don't have to think about, do we have to keep people who are very ill, we can send them to the hospital. If you go to those websites, you'll have a really good feel for the risk in your area. Remember, what is common is common. If you're in New York City, COVID-19 is common. If you're in other places like my town in Charlottesville, Virginia, it simply is not. And we have to think in those terms. Okay, let's switch gears and talk about treatment. Like most viruses, the treatment is supportive. I hate the headlines that say there is no treatment for COVID-19. That's as frightening as can be. Um, really, we treat the symptoms. That's what doctors have always done. We treat the organs affected. Yes, there's no specific medicine, no specific vaccine, but there's so much we can do that saying there's no treatment is just not right. Next slide. So if you're taking care of a patient with COVID-19, it's pretty straightforward. You put them in isolation or with another COVID-19 patient. That's called cohorting. You have standard contact droplet and eye protection. That's a gown, gloves, face mask, and goggles, or however your eye protection is. And you double mask or use N95s. In a study that was done last year, double masking, meaning the patient wears a mask and the caregiver. It does not mean you wear two masks. Both people are protected, or you can wear an N95. They're about equal. You'll get good protection. Remember the desert island thing. So if a person is suspected or they have it, you want them to wear a mask. Plus, when you walk in the room, not 24/7, when you walk in the room, say, please put your mask on. You have your mask on. And then you want to push fluids in these folks, rest and nutrition. You want to get them out of bed because getting out of bed actually gets the lungs stimulated, and deep breathing exercises. Next slide. A quick word about medications, and I'm not going to go through this in detail. You have these slides. Chloroquine and hydroxychloroquine, they're being touted by lots of people. The clinical data is very, very limited. I'm not overly impressed with either one, but I would call it mildly encouraging. I have just sent an email out to everybody on our 60-something nursing homes that we will not be using hydroxychloroquine uh, prophylactically and not for treatment either. My feeling is if they need these medications, they need to be out. I just saw 5 minutes before this phone call, AMDA has recommended the same thing in all nursing homes. Next slide. The combination that's very popular right now, it's a triple combination actually, hydroxychloroquine, the Z-Pak, and zinc. People want to do that. That should be done in the hospital. I don't think it should be done in our facilities. If a person is sick enough for medications, they're sick enough to go out. By the way, we at our company have been leading the industry in reducing readmissions. We've done wonderful work. This is not the time to reduce readmissions. If people are getting respiratory illness and they're deteriorating and they might have COVID-19, you send them to the hospital. You know why now? I showed you the mortality numbers. They're very high, sooner rather than later. Now, the two best possibilities are remdesivir, which is the anti-Ebola drug. Number 5 is an HIV drug, which did not show any promise. But the next slide shows convalescent plasma. That's when you use the plasma from people who have recovered, and that seems to be very effective. And you can see here symptoms disappeared in 1 to 3 days, and the viral load was undetected. So convalescent plasma seems to be the way to go if you can, and then remdesivir. Okay, next slide. Now, the key thing is pandemics require us to make decision making. I had to determine for our 60 plus nursing homes, is getting a haircut essential? Can people go 6 weeks, a month, 2 months without a haircut? It's non-essential, right? Dialysis, it's essential. And remember, those folks who had increased risk. Podiatry, not essential unless there's pain. Physician visits, well, we're trying to limit them. Determine on a case by case. Dental, non-essential unless there is pain. Next slide. But some things are essential. Therapy, for example, is essential. In my mind, it's not an optional service. There's a window of opportunity for improvement, especially in the elderly. Think about a person with a stroke. Think about a person after hip surgery. They don't get therapy, they never get better. It's almost like this: if you lose it, muscle strength, function, flexibility, it can be very hard or almost impossible to get back when you're 70, 80, 90 years old. And we can make our therapy centers safe by following all of the steps I've outlined. Aegis as a company is cutting edge on this. Next slide. But some facilities are restricting therapists from entering. I understand this. It's a fear. I just saw this county order. Discontinue all personal care services, and it said physical, massage, occupational, unless there's a critical need. Next slide. In my mind, therapy is essential. I just heard about an ALF that said, we don't want any therapy coming to our center. And then 2 weeks later, they called with 16 referrals because they said, our patients are falling. They can't eat. They're choking. They're not doing well. So therapy is essential. Consider the impact on function. Consider the impact on patient and family expectations in your nursing home. And consider the regulatory impact. If you state in your plan of care, this person needs rehabilitation, and you don't order rehabilitation, you can get a citation. You can have tags, of course, and even fines and Jake severe tags. Next slide. So I made a list why I think therapy is essential. It eliminates or reduces pain. It helps people avoid surgery, helps them do better if they need surgery. It improves mobility, helps people recover from strokes and heart attacks, injuries, it prevents falls, it manages heart and lung disease, and it helps keep people out of the hospital. I don't see how a person really can see therapy as non-essential. Next slide. So as I conclude here, I want to give you the power. I want you to know that from this lecture, you have the power. I want you to think about practicing good health habits. Eat well, keep hydrated, get adequate rest, stop smoking, exercise, prayer and meditation. Practice gratitude, count your blessings. Don't get caught up in the negative thinking of the headlines and the 24/7 news cycles. Next. You have the power by practicing good infection control, respiratory hygiene, cough etiquette. Practice hand hygiene at work and away from work. Don't touch your eyes, nose, or your mouth. How many times have I said that in this talk? Practice social distancing at work and in public. Right now, everybody on this call, stagger breaks. I just was talking to a nursing home, they had 6 people in their break room. Stagger the breaks. Do social distancing for meals. Everybody should practice social distancing to the best of their ability at work and in public. Understand PPE, know when to use it, know how to take it off and put it on properly. Do that stuff. Read those manuals that you skipped in the past. You need those. Next. Now monitor yourself for fever, signs of a new respiratory infection. But remember, what's common is common. Now, let's say when you come home from work, Wash your hands immediately. Do some infection control of your personal devices. I'm mainly thinking of the cell phone here, but anything that's been out in the public, wipe them down quickly. Now, let's say you work in a SNF, nursing home, or an ALF, and you have patients who are COVID-19 positive, and you have a high-risk family member, and you were potentially exposed. Take off your clothes when you get in. Well, first of all, wash your hands immediately, clean your phone, take off your clothes, put them in the washing machine, and then take a shower. Your chance of giving it to your family members, if you have done everything I said during the workplace, you wore a mask, you didn't touch your eyes, your nose, and your mouth, you tried to stay away from direct face-to-face contact with people, your chance of giving this to somebody else in your family or getting it yourself is close to zero. But if you have a high-risk family member and you do this last step, it's still close to zero. You have the power in your hands, so take it and use it. Next slide. So I hope that this lecture has woken up the complacent, but I also hope that it has comforted those of you who are worried, those of you who tend to panic, because really the scientific data should wake up the complacent. But if you've been a worrywart about this, it should comfort you to know the scientific data now, because you do have the power. Next slide.
All right. Thank you, Dr. Avery, for that tremendous fact-based presentation. I know each time I listen to you, I learn something more, and I find myself calmed by your information. We do have a few questions that have come in that I'm sure we'll have time to address. So the first question, the questioner says, I have a family member who tested positive for COVID-19, and it's day 7 since the first symptoms. When can we really say that that person is no longer contagious?
So we would use the CDC definition for contagious and say 14 days fully, because then we're definitely 100% sure. But if you're 7 days out, the chance of you getting sick, and because remember, or being contagious is very, very, very slim.
Great, thank you. Next question, you spoke about just a little bit, maybe removing your clothes, but the question is, do we know how long the virus lives on clothes or soft surfaces?
Yes, that's a good point, because I picked the surfaces where the virus lives the longest. The longest surface it lives on is plastic and steel. Cardboard, 24 hours, cloth and things even less. And remember that study, the half-life on soft things is very, very low. So on clothes and such, it's very, very low. But if you've worried, if somebody coughed on you, you didn't have a gown on it. And you remember the desert island example. Gowns, if you have a choice, face mask or first, eye protection second, gloves third. Why? Because I don't want you to touch your eyes or your nose or your mouth before you leave the room. So if you've touched anything, you take those gloves off, it's less likely. Gowns are way down on the list because of that. On the other hand, if somebody coughs right in front of you, somebody spit on you, you had splashing of some bodily fluid or something on your clothes, you definitely want to put those in the wash, take them home, take all your clothes off, throw them in the washing machine. Don't touch those clothes until you get home, or change your clothes at work, because the tendency might be to touch it and then touch your nose or your mouth. Now remember, even if your clothes are soaked in COVID-19 virus, you only get it if you touch the clothes and touch your eyes, nose, or your mouth. It cannot get through your skin. Your skin is a barrier against viruses.
Great information. Next question is there evidence or have you found any kidney involvement with COVID-19 virus patients?
You know, that's a good question. I have not seen any evidence that patients with, say, mild to moderate renal insufficiency are at increased risk, but dialysis patients are at significant risk. And that's why really, if you have dialysis patients, they should be put in a separate room or at least cohorted. They should wear a mask regardless of whether there's COVID-19 in your house to protect them. They need to wear a mask, of course, when they leave the facility. It would be ideal to change their clothes when they come back, and always make sure anybody coming in is washing their hands, using hand sanitizer. Dialysis centers are very attuned to this, and they are really working overboard to protect these patients. So put dialysis patients higher on your list. But if you have mild to moderate or renal insufficiency or kidney disease, I've seen no evidence that you're at risk. It's the dialysis setup centers that make the person vulnerable.
Great, thank you. Next question is appreciating your recommendations for PPEs, particularly the N95 masks. Clearly that is desired for the care of the patients, but we know that the availability is limited. Do you have advice?
Yeah, so the key is that 2019 study that showed that double masking was equivalent to an N95. Now, and not equivalent to, it's an equivalent to you wearing an N95, the caregiver, the nurse, let's say, or the CNA, and that's equal to the patient wearing a mask and you wearing a regular surgical mask. N95s are ideal when you have a COVID-19 positive patient. Because N95 mask, I can't hardly wear those things for more than an hour. They get wet. I feel like I'm suffocating. Because of that, for an N95 mask, would be ideal. But again, double masking is just as well. By the way, if you're going to do an N95 mask, make sure you're doing it properly. Do the fit test. Aegis has an incredible video that they use for training, and they also have a beautiful handout. Ask your Aegis therapy folks for that access to that video or for that handout. It's a great one that shows pictures, how to put it on, how to take it off, and how to self-test yourself, because it's hard to just fit test. Everybody needs to be fit tested. And right now, just do the best you can by training people with the videos and with some of the handouts.
And a related question, Dr. Avery, on the N95s, the questioner is wondering, what about the masks that are labeled as KN95s?
I'm not familiar with that, but the CDC actually has a website. Oh, no, OSHA, I'm sorry. OSHA has a website where they actually rate the N95s. Because if you remember early in this thing, the US government had said do not use N95s from certain countries. So when you go on the list, and maybe that's where these different letters come in, I'm not positive, they will list the different types of N95s and what countries they came from. And I can tell you, I happen to notice the bottom country on the list was China. N95s from China are thought to be less reliable, but this federal government is saying they're still better than surgical masks, so use them. But OSHA has a great website for that.
Thank you. Last question, two more questions, Dr. Avery, and then we'll conclude. Can you comment at all on the risk or higher risk potentially for those who are post-organ transplant?
Post-organ transplant, that would be high risk. I would put the folks who had a successful organ transplant and are on the medications that reduce the immune system at high risk. I would put them in the same category as people receiving chemo. Folks, yeah, those two would be in the highest category, and that would mean trying to avoid settings where you could be potentially exposed. Clearly wearing a mask at all times. N95s would be preferable in that setting. Taking all your clothes off when you get home, like we talked about. Making sure you do everything we just mentioned. take extra care in that setting.
Very good. Final question, Dr. Avery. You mentioned double down with community safety and delivery services and such. The questioner says, what about getting a sub sandwich from Subway? Is that as safe as a hot meal to go?
So hot meals are better because hot meals are going to be safer in general because the virus actually is killed fairly easily with heat. So I think if you're going to do takeout, yeah, there's some preferable of hot meals versus less. The problem isn't the food. This is the take-home message from Take-Home Food. The problem isn't the food. The problem is the packaging. If a worker at Subway sneezed on the packaging, you know, so I think the key is opening up the packaging, getting the food out of the package, washing your hands again at that point. The other option is to wipe down the packaging, which I think is impractical. More likely, get the food out, put it on a napkin or something, wash your hands again because you've touched the packaging, and then I think you should be just fine. And particularly a hot meal would be safer than a cold meal. But I think in general, the risk from takeout is very slim. I just myself went to a Subway yesterday, and I can tell you that everybody's wearing masks and everybody has gloves on. They seem to be very attuned to this.
Very good. Well, that concludes our time available today. Dr. Avery, thank you again. We are so grateful that you make yourself available to share this terrific information. Thank you to the audience again for all of you that have attended. We appreciate that, and hopefully you found this helpful. Again, just as a last reminder, we will be sending you access to the slides as well as the recording, and both can also be found on the aegistherapies.com website in the COVID-19 resources section. Thanks again for attending.